Excellent summary, Rami. Thank you so much for extensive review in a short time period from diagnosis to prognosis to therapy, including the tips on the management style with different JAK inhibitors in particular. But let's all us together discuss from the beginning, first the diagnosis, because diagnosis appears to be problematic in some cases, particularly when the sampling of the bone marrow is not good enough, when the molecular testing for the driver mutations is not good enough. And we have to understand that the diagnosis actually combines different aspects of what one sees in a patient. It's not just the bone marrow. And perhaps, Prithvi, you can help us here. What does actually entails to get the diagnosis of myelofibrosis, and what needs to be ruled out that we wonder when we have fibrosis in the bone marrow? Is it always myelofibrosis or can it be something else? So what are the diagnostic criteria and what needs to be ruled out?
Sure, Serge, thank you. The primary myelofibrosis diagnostic criteria, there's quite a few. There's major and minor criteria, but one point I'd really like to make is you're looking for megakaryocytic atypia. You're not just looking for proliferation, because you see that in ET as well. But the atypia is really, in my view, the hallmark of primary myelofibrosis. Of course, you have several minor criteria such as anemia, splenomegaly, increased LDH, leukoerythroblastosis, etc. You certainly need the clonal marker, and you touched on this. Sometimes we don't have a driver mutation. In about 10% of patients, we don't have JAK2, MPL, or CALR mutated, and that's what we call triple negative primary myelofibrosis. But there too, using a myeloid mutation panel, an NGS panel, which is getting increasingly prevalent nowadays, can really help, because you find these non-driver mutations, mostly epigenetic and splicing mutations, ASXL1, TET2, EZH2, DNMT3A, SRSF2, etc., SF3B1, which can really help you show that this is in fact a clonal disease. Other diseases, sure, can cause myelofibrosis without being clonal. So infections, autoimmune conditions, certain drugs even, certain recreational drug toxicities, but particularly some autoimmune conditions, lupus, for example, but those are not going to have a clonal marker. So yes, it's really a combination of a lot of factors, pathologic, genetic, laboratory, as well as clinical.
So it seems that it is a clinician who actually makes a final decision, because you have to combine the bone marrow exam, including the molecular and cytogenetics. You combine the physical exam, you have a chemistry, this is LDH, and you have a blood count. All this needs to come together, and the clinician many times is the one who makes the final decision. But you already mentioned the mutational analysis beyond the driver mutations. Testing for the JAK2 mutations, calreticulin or MPL mutations is part of the diagnostic process, and it's one of the factors accounted for. But other mutations you already mentioned may have a role in a differential diagnosis if there are questions. Andrew, the mutation analysis gets handy not only in these borderline cases, but also for prognostication. Is this something that we should be doing quite often, extensive molecular testing? And what's your take on that? Where, apart from diagnostic differential here, where else should we do it and how often?
Yeah, I think that certainly the NGS has allowed us to do molecular panels much more easily than we were able to do in the past. And certainly with diseases like myelofibrosis, we typically do molecular panels, broad molecular panels on virtually every patient that comes in. I think that they provide a lot of information. Diagnostic, we touched on, prognostic as well. And increasingly, we're starting to have the potential for this providing some therapeutic benefit as well. So I think Dr. Kamraj talked a little bit about some of the prognostic gene mutations such as ASXL1, SRSF2, EZH2, U2AF1, IDH1 and 2. Certainly, I think those are helpful and give us a sense of where exactly we think this disease might go, and it may act a little bit more aggressively than we would have thought otherwise. But you know, diagnostically, you may suggest or think you're seeing something like myelofibrosis, but you could see some combination of a CSF3R mutation or a combination of TET2, ASXL1, SRSF2 that makes you rethink the diagnosis and maybe consider something like chronic neutrophilic leukemia or atypical CML or CMML, which can really sometimes present some overlapping features with myelofibrosis. I think the idea of potentially being able to use these as therapeutic is really where we need to get to and where we're kind of going. And certainly with the IDH1 and 2 inhibitors, you know, there becomes the potential to use that, and increasingly we're starting to come out with more molecularly targeted treatment that could be used in some of these cases.